We'll start with the first presentation from Medicine 4.
Good morning, everyone. Presenting from Medicine 4, Hereditary Bane. His master is a 16-year-old man, male studying in 12th standard from Jharkhand, who's presented to us in the OPD with chief complaints of sudden weakness all over the body below the neck, which settles after taking syrup KCl. History of present illness. He was apparently well 10 days ago when he traveled home from his hostel and developed generalized fatigability with associated muscular pain. He took over-the-counter medications for the same. The next day at around 6 a.m. when he woke up, he was unable to lift up his hands. He was able to sit up on the bed but was unable to get up from squatting position. He was able to walk with the help of his relatives. He took syrup potassium chloride 20 ml 5 times and oral acetazolamide, following which the symptoms subsided by 6 p.m. He did not visit any hospital for the same. There is no history of intake of any native medication, no history of any vigorous activity. There is no similar history in the past. Family history, his mother had similar complaints for the past 18 years. Her symptoms started when she was 18-year-old. She was prescribed syrup KCl and oral acetazolamide. She takes it as and when required. Her symptoms recur 1 to 2 times a year. His grandmother and great-grandmother also have similar complaints. His mother's brother died of similar symptoms due to non-availability of syrup KCl during COVID lockdown in Gujarat. Father has no complaints and he has a younger brother who's asymptomatic. At presentations, his vitals were BP at 120/80, pulse at 110 per minute, respiratory rate at 28. CNS, there was no significant CNS abnormality, higher mental function was normal. Cranial nerves, there was no deficit, sensory system was normal, reflexes were 2+, motor, power and tone was normal, there was no sign of meningeal irritation. Per abdomen was soft, non-tender with no organomegaly, respiratory system, bilateral, normal, no added sounds. CVS S1, S2 was normal with no murmur, sir. What do you think would be the differentials for this? So we have a 18-year-old young male who has a family history of weakness, motor weakness that is there, which resolves on taking syrup KCl. He similarly presents with a new onset symptom of the same sort.
Seem to be.
Okay, we'll just go ahead with the presentation. So the differentials we had considered were primary hypokalemic periodic paralysis, hyperkalemic or normokalemic periodic paralysis, thyrotoxicosis induced periodic paralysis, Anderson-Twill syndrome, secondary hypokalemia, myasthenia gravis, and paramyotonia congenita. On investigations at the time of arrival to our hospital, CBC was at HB 12.8, WBC of 9,000, platelets at 2.3 lakh. Urea creat, LFTs were within normal limits, sodium at 139, potassium at 4.7 with a bicarb of 26. Urine routine was normal, urine spot sodium was high with a urine spot creatinine of 127. Urine spot osmolality was 807, which is within normal limits. CPK at 106, urine 24-hour calcium was 25 with a spot chloride of 61. Phosphorus was 4.7, TSH, T4 was within normal limits. Renin, aldosterone within normal limits. Just looking at hypokalemia as an approach. So the diagnosis that we made was of a periodic hypokalemic periodic paralysis. Just looking at hypokalemia from Harrison, Patient presents with hypokalemia. If it is a pseudo hypokalemia we're thinking of, there's no need for further workup. If it is an emergency before any sort of evaluation, it is necessary that we move to treatment and then continue further evaluation. If not, take a history physical examination, and based on lab diagnosis, if we can see a very clear evidence of transcellular shift, intracellular shift, we treat that accordingly. So that is seen in case of insulin excess, beta to adrenergic agonist, familial hypokalemic periodic paralysis, hyperthyroidism, barium intoxication, theophylline and chloroquine. If not, there is a clear evidence of low intake, treat accordingly. The second step, if these are not there, is to look for urine potassium. The urine potassium creatinine ratio of 15 is generally taken as the cutoff. Less than that, we look for extrarenal cause of loss, and more than that is generally a renal loss. For extrarenal loss, we look at the acid-base balance. Generally, acidosis, we're looking at a GI loss. Alkalosis, we're looking at normal to alkalosis range. We're looking at profuse sweating, diuretic use, and vomiting. If you're thinking of a renal loss, we look at the transtubular potassium gradient that is there. So if it's less than 2, it's we're generally looking at a tubular flow, increased tubular flow causing osmotic diuresis. More than 4, we generally take for increase the distal tubules are secreting more of potassium, that is causing the loss. So that's where we look at the BP and the volume status for the patient. If you're looking at a higher BP, we're looking at renin, aldosterone, that set of diseases along with cortisol, high cortisol levels. If you're looking at a normal or a low BP with a normal volume status, we look at again the acid-base balance, where we look at metabolic acidosis. We're looking at all the renal tubular acidosis that we have. Proximal, distal, DKA is the other differential that can be considered. In case of alkalosis, we look at the urine chloride. If the urine chloride is more than 20, we are looking at loop diuretic use, Bartter syndrome. If it is less than 1.5, we're looking at thiazide diuretics and Giffinan syndrome. Less than 10, again, we are looking back at a normal urine chloride level. So we're looking at chloride diarrhea with or vomiting. Coming to hypokalemic periodic paralysis, it's a channelopathy. It's a skeletal muscle ion channel mutation, which causes sudden onset of generalized or focal flaccid paralysis associated with hypokalemia. Generally, are high carb diets or strenuous exercise. So two aspects of it, acquired or familial. Acquired is generally associated with the conditions we looked at in the tabular column we just had. So it's either hypothyroidism, there's a renal loss, or a gastrointestinal loss. Familial is generally mutation in either the sodium or calcium channel. So there are 2 familial types that have been described. One is mutation in the skeletal muscle calcium channel, which is a CACNA1S type of channel mutation in that. And the second one, which is a calcium channel. And the second one is a voltage sensitive skeletal muscle sodium channel, which is SCN4A. So both these spaces, what happens is there is intracellular retention of potassium, causing less potassium in the outside circulation, which causes a hypokalemia. Most familial cases have an autosomal dominant inheritance pattern. So lower clinical expression in females because of lower penetrance, and the attacks of rate are more in male as compared to female. In our patient, it was an autosomal dominant pattern. So number 5 is where our patient was. This is the pedigree chart for the patient. Patient's mother was affected. Patient's grandmother was affected. Along with that, this is where our patient was. Patient's mother was affected. Grandmother was affected. This is the brother who died because he could not access KCL during the COVID time. Both his children. Yes. So the differentials we considered was, the other thing is hypokalemic or normokalemic periodic paralysis. Classically, these during these episodes of flaccid paralysis, the potassium levels are high. These are generally precipitated by low carb diet, unlike what was there in our patient. Thyrotoxicosis, periodic paralysis, our patient did not have any derangement of TSH-T4. Anderson-Tawil syndrome, it's a KMCJ2 mutation. This also presents with flaccid paralysis, but along with that, there is cardiac and skeletal muscle involvement. So there are skeletal muscle deformities like scoliosis, some facial deformities like loci tears, ocular malformations, along with cardiac abnormalities of ventricular arrhythmias, ectopic beats. Secondary hypokalemia, again, GI loss, renal loss, we looked into it. The patient did not have any of it. Myasthenia gravis, characteristically presents with fatigability, diurnal variation. Paramyotonia congenita is generally presence at a lower age group, first to second decade of life, and very characteristically, it involves certain muscle groups that are there, ocular muscles, neck muscles, upper limbs. So generally, it's a grouped muscle involvement that we generally see. So for our patient, we were back to prescribing him syrup KCL as and when required. We did send genetic markers for the 2 mutations that we were expecting.
Thank you. I have 2 questions before I throw it open. What is the role of acetazolamide? Why are people giving acetazolamide?
So as a diuretic, it causes potassium retention that is there. So that is, it's not a very well-studied thing, but in some cases that can cause, I mean, it can increase the potassium that is there. The renal loss is kind of avoided.
You haven't proven beyond reasonable doubt that this is hypokalemic.
Yes, because we don't have, during the episode, we don't have potassium values that are there.
Any questions or comments from the audience? PG should ask. Anyone else? Yes, Nando?
But no, in your algorithm, you said, no, like he's very, when you have signs of severe hypokalemia, you treat immediately, or if he has sick, could you just, for the benefit of the first years, tell us what you would look for and when you would start giving out the correction before you would?
Yeah, so we're looking at,
what are the symptoms and signs that you would be like, he's very, very sick, I would start with the treatment before it.
yeah, potassium values generally is in 2.5 to we generally try to treat patients presenting with excessive fatigability, muscular weakness, cardiac ECG showing cardiac changes. Those are places where definitively we have to treat before we go ahead with the other recommendation.
Any other questions? Okay, thank you. We'll move to the second one. Who's presenting?
Geriatric is after this. Geriatric is after this. John present.